Welcome to the Rocky Mountain MS Center's webinar series. This series is designed to give people with MS information to empower them to make the best choices for their lifelong brain health. I would like to thank the pharmaceutical companies who have provided support for this program. Thank you to Genentech, Novartis, and Sanofi Genzyme. Today, January 7th, 2022, we will be giving an update on COVID-19 variants, boosters, and treatments. This presentation features Dr. Enrique Alvarez. Dr. Alvarez is the Vice Chair for Clinical Research at the Rocky Mountain MS Center at the University of Colorado. He is a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. This webinar features a lot of important information and may go longer than 1 hour. If you missed something on a slide, want to hear it again, or cannot stay until the end, we are recording this webinar and it will be archived on our website at www.mscenter.org so you can replay it at any time. All live viewers will get the recording automatically sent to them. We'll reserve time at the end to answer questions from the audience. You can submit your questions at any time by typing them in the chat window on your screen. We will answer as many questions as time allows. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, we'll turn it over to Dr. Alvarez.
Awesome. Let me get the screen shared.
Good.
Perfect. All right. So thank you everybody for tuning in today. This already marks our 11th webinar update on COVID, which I never thought we would get to. It's one of the more highly attended ones. So I hope we have a good discussion at the end. There are a ton of questions. And I think as things are kind of been moving up with Omicron, it becomes a little bit of a moving target as far as a lot of the guidelines. So I hope I can kind of give the latest guidelines, but please keep mindful that a lot of these have been changing over the last week. And so there's a lot of changes happening. So that's part of the reason for this update. And I think it's part of the reason why we have such an interest in it. I've tried to get a lot of data updated through today. So where not, I tried to I'll point that out as well. But we'll go from there. So we are hitting our largest peak so far, and it's mainly due to Omicron, entirely Omicron at this point. We'll show a little bit of data that. We've talked a lot about risk factors, so I'm not going to get into a lot of that today, just kind of provide a little bit of a quick overview. A lot on vaccinations, third doses, boosters, and the little bit that we might know about Omicron. We'll talk a little bit about vaccine myths. This I presented already at the Ed Summit, but I think we're still getting a lot of questions about this. And so I think it's important to kind of go through that, although I'll go through that pretty quick. There's a lot of treatments that are coming out. These are monoclonal antibodies, antivirals. We'll talk a little bit about some of this data. It's important to recognize that we don't have a lot of data specific to MS patients. So I think a lot to kind of come through still. And then we'll provide some guidance. And I'm going to say right now what the overall punchline is going to be is just get vaccinated, because in spite of all the other stuff that's out there, it's much easier to get vaccinated than to try and modify some of the other things like getting younger, having a sex change, fixed disability, cure MS, or other things like that that we've been working on for many, many years at this point. So with that, let's look at the numbers. And I think you can see how much this spike has surpassed the prior spike. The third wave, we're in the mix of, whether sometimes people will call it the fifth or the sixth wave now. But you can see that we're topping, 600,000 cases, much more than we had, almost 3 times as much as we had back in early 2021. The great news so far is that when we look at hospitalizations, these numbers haven't quite shot up past the hospitalizations from that third wave, and the deaths are much lower than they have been in the past as well. So we could see that there's been a 227% increase in number of cases, but that's not been reflected yet in hospitalizations and really not in deaths. So that's the great news. And, some people are starting to kind of say, well, Omicron maybe is a milder version of the virus and things like this. That may be true. I suspect that a lot of that is simply because people have been vaccinated, and we have a lot better treatments for it than we did sort of at the beginning during these first few waves. That being said, look at the number of deaths in the United States. We're approaching almost 1 million deaths from COVID alone. And I can guarantee you, or at least I'm not getting any money paid for diagnosing anybody who dies with COVID, as one of the myths, to get one of those myths out of the way already. Some of this could be just a delay as well. We know that hospitalizations tend to lag cases by a couple of weeks, and there really hasn't been 2 weeks yet in that little short time frame. And we're starting to kind of see these great increases. So it's a little bit hard to know what that's going to look like. And then the delay for deaths is a couple more weeks, and that might be just what we're waiting to kind of see as to what happens. So big spike in number of cases. Hospitalization numbers are starting to kind of go up, and I'll show you kind of how recently that's been the case in the Denver metro area, and really deaths kind of staying stable at this point. So to show a little bit about how fast things have increased, these heat maps with darker colors showing higher rates of COVID. We're talking December 27th, 4 days later, another 4 days later, and another 4 days later. And you can just see how, it's blowing up kind of throughout the US. This has definitely sort of been a really fast, sharp spike. When we look at the number of cases, we can see that the number of cases has surpassed easily that third wave that we saw in Colorado. And I think the scary part a little bit is that the prediction modeling is showing that this is not going to probably let up for at least another 3 weeks until February 1st. So this peak right there is January 31st, February 2nd, somewhere in that time range where we're seeing that peak come through. When we look at number of hospitalizations, the predicted peak has it not being quite as bad as the other peaks, which is great, but notice the big range. The other concern a little bit is that's today, I just got this data, and you can see that there's been, according to this, no increased number in cases of hospitalizations. The bottom line is ICU cases. And to me, this is a little bit concerning. I currently have 2 patients in the ICU with COVID, and so a concern there. But to show a little bit of issues kind of where these numbers are not probably being reflected quite yet, is if we look at the numbers from our hospital, we can see that we've been kind of at a steady number now for several months, around 260, 270, something like that. And over the last handful of days, this is through January 4th, this was the latest data I could get. But you can see sort of how these numbers have been spiking up, including a 48 bump up in number of patients. So we're up to 349 on the morning of January 5th. And that is a concerning number, going up by 20-25% in just a matter of a week could be a concern. It could be just a blip, and hopefully, fingers crossed, maybe that's what it is. This positivity rate, though, if you look at the tests being done at the university, we look at this number a lot, and we've been sort of in the 8, 9, 10% range up until about the last week, where now we're starting to see this range just skyrocket and get into the low 30s now. So that means that about a third of tests, people who come in with a stuffy little nose or any little symptom, it's turning out to be COVID. So this is the predominant virus kind of going around right now. When we look at this, one of the things that gradually we've been starting to kind of collect data for has been data around the types of variants. So this data didn't start accumulating right away, but we started getting it last year. And you can see that initially it's this dark blue variant. This is the original, the alpha variant that was out there, followed by the Delta variant. And you can see now how Omicron and how fast it's just overtaken this. So we're at, as of last 2 weeks now, 100% of cases in the state of Colorado are Omicron. It is crazy to think that a virus can overtake another virus and basically, drive it to extinction, if you want to think about it that way, which is what Omicron has done. You can see how fast this has gone up compared to like these other waves for the Alpha, which were, much more over several months. And even the Delta variant that was, much more transmissible, here you can start to see a little bit of it. And it took a while for it to kind of replace that the other original virus that was there. And there's been little other variants that have kind of come and gone and things like this. So I think this is the part about Omicron that's kind of has us hurrying to try and get information. And again, this is part of the reason when we start talking about guidance and does this drug still work against Omicron? The answer is it's going to be hard to know, because really we didn't see this until 3 weeks ago in the state of Colorado. All right. As a reminder, these are getting named for the Greek alphabet. And so you can see alpha, beta, gamma, delta, epsilon, zeta. So there's been a lot of variants that have kind of come and mostly gone. So we got the alpha, the delta that we've heard about. There was some concern about mu, because mu was going to be probably very resistant to vaccine, but it didn't seem to make it. And now we're all the way up to the Omicron variant, and new ones keep popping up, but this is probably one of the next ones that may come up after the Omicron one. So first sample to test positive for Omicron was on November 11th in Botswana, followed by a case, some samples in South Africa that became positive by November 14th. One of the nice things is we can use a little bit of this data, but even using this data is only, not even 2 months old. And we really didn't get reported to the World Health Organization until the end of November. I think it was like November 24th that it got reported to the World Health Organization that the strain was identified. So we're kind of looking at data for the last month is the point for this. So what are some of the things that we can learn? It may take only 3 days to develop symptoms. It can become contagious and test positive, compared to maybe 4 to 6 days with Delta. So it definitely seems to kind of be a little bit of a quicker turnaround virus as far as giving you symptoms. Some of these things may be a good thing in the sense that they may have a little bit less of a asymptomatic period where you can walk around without knowing that you have it. Omicron does appear to have less fever and cough and loss of taste and smell, but it looks like it's more associated with a runny nose, sneezing, headache, and fatigue. It looks like, at least in some experiments and all things hamsters, that Omicron really likes the upper respiratory tract, meaning sort of the nose, the sinuses, the back of the throat, much more so than COVID that likes to go much more so to the lung. So that's a good thing in the sense that if that really turns out to be the case, some of the long hauler syndrome might be predicted to be less of an issue. Again, it's not been around long enough to become long haulers, so we don't have much data as far as that stuff goes, because most of the patients who got Omicron are just starting to recover from it. Is it more infectious? So it looks like, at least in vaccinated people, that it is 2.7 to 3.7 times more infectious than Delta in vaccinated people. Again, these are hard numbers because a lot of us have been vaccinated, and remember, we were vaccinated against the Alpha variant, so the original COVID strain. And there was pretty good crossover with Delta. Omicron is a little bit different, and that's probably why we're seeing a little bit of a fall off compared to Delta in vaccinated people. It does look like there's less hospitalization and deaths, but again, we've not had Omicron around long enough to maybe see those bumps yet. So, fingers crossed that this becomes true. And again, this idea that maybe it's a milder disease could be simply because we do have some protection from vaccinations and prior infections that might be driving some of the protection against Omicron. I couldn't find the original data, but there does seem to be at least anecdotal data that people who just got vaccines may not have as much of protection to Omicron. We're seeing a lot of people who have gotten COVID once and even twice who were vaccinated. But people who have gotten the booster seem to be a little bit better protected. And I like to provide examples when I can. There's somebody that we work with who over the holidays was around their family and all 10 people became sick. I think it was something like 4 or 6 of them had boosters. The other people were all vaccinated. The people who were not vaccinated, who were not boosted, developed fevers and chills, and the other people developed much more of the runny nose and that kind of stuff. And it was pretty much consistent. So I think there's some learning points about this, about, more boosters is probably better. It just provides better protection. And this was not MS patients. So no issues around immunosuppression at that point yet. All right, so let's talk about vaccines. Where are we at in this kind of stuff? So we are doing pretty well in our older populations. At least 95 have gotten 1 dose and 88% have been fully vaccinated. As we start to talk about kids, those numbers start to kind of drop off a fair amount. This is for the United States. As we start to look at vaccine responses, there's been a little bit of a gradual drop in how severe cases might be. So in other words, if we look at average daily cases for people who were fully vaccinated versus unvaccinated, the unvaccinated had 5 times as high a number. Early on, it was more like 7, 8 times as high. So that could be a little bit of this drift with the Delta variant, I suspect. When we look at deaths, though, we can see that vaccines, that little bit of protection that you may get might not prevent you from getting the disease, but it might prevent you from dying. Again, early on, that number was closer to 15 to 18 times as higher for the unvaccinated than the fully vaccinated. So the unvaccinated are much higher risk, again, of dying and of getting sick. So I've presented these numbers, and I've not seen these numbers from our hospital recently. This was from November 4th, and I've shown these numbers before, showing that in the state of Colorado, mostly in the metro area, that for hospitalization, vaccination really still reduced the number of people that we see in the hospital. So if you look at the number of people that are vaccinated in the state, it is in the around 70%, but only 22% of people in the hospital were vaccinated. That number drops to about 9% in the ICU and 8% for being ventilated. So vaccines are helpful. They're not 100%. We don't have a drug in MS that works 100% of the time. Even our beloved Ocrevus and rituximab, Tysabri are really high efficacious therapies that we use a lot, are not 100% of preventing attacks. So we got to stop thinking about these drugs being 100% for anything. Medicine doesn't work that way, and I'm not sure of anything in life that works that way. So this number maybe mostly probably represents Delta variant. But I was able to find a very similar set of data from January 4th, so just 3 days ago, from the Sanford Health System, from where I came down to Colorado from, in North Dakota, South Dakota, and northern Minnesota, where we can see that these numbers are holding up still really pretty well. So again, 12% of patients in the hospital were vaccinated. 11% of patients in the ICU were vaccinated. 10% of people on ventilators were vaccinated. And again, vaccination rates have only gotten higher. So this really gives us good information that probably against Omicron, that we're still seeing good efficacy of the vaccines. Again, not 100%, but giving us some good response to that. So how good is vaccination versus natural immunity or natural infection? This data is a little bit old, so this is, again, mostly against Delta, but looking at a large number of patients who were hospitalized from a lot of different hospitals that form this Vision network. And what we can see is that unvaccinated people with prior infection within 3 to 6 months were 5.5 times as likely to have infection that those who were vaccinated 3 to 6 months before the infection, meaning people who are vaccinated do better than those people who got natural infection and were not vaccinated. It just provides a more robust immune system. And some of this is just, mild infections not giving you good protection, good immunization from that. So can having COVID count as a booster? It can. It definitely provides some protection, but it may not be as good as a vaccine. And some of this depends on how sick did you get from COVID. If you had a runny nose and that kind of stuff, probably less so. If you had very robust and you were really sick and were hospitalized with COVID, then you probably mounted a much better immune response and might be better than vaccine. So again, it's not black or white. It's just trying to kind of adjust for, how much can you replace one of the vaccinations with having had COVID. Let's talk a little bit about protection. I've shown some of these next slides before, but I think it's important to remember that the way we protect ourselves involves a lot of different steps. Natural killer cells, the macrophages, having a good barrier, so not having lung disease where the virus can maybe make it through a little bit easier. Those kinds of things, that's protected in all of us. And then we talk a lot about B cells and T cells. B cells tend to have some ability to kind of talk to T cells and provide some protection that way, as well as becoming plasma cells and making antibodies. So we get worried a lot when we take out B cells, whether that is directly with things like Ocrevus and rituximab or ofatumumab, but also when you have some of these cells put away in lymph nodes with things like Gilenya and some of the other similar drugs. There's some drugs that also affect T cells, and that includes some of the Gilenya. So some of those drugs may have a little bit more of an effect than we might even get just from the B cell depleting therapies, because those still make good responses from this. And when we talk about monoclonal antibodies, if we can give you this and you have this, then you have a pretty good immune response. So the idea is to trying to see, how immunosuppressed are we? And that's going to vary a lot with our different drugs. And again, taking out the B cells with some of these drugs. So if we do that, we can see the effect of one vaccine versus 2 shots. In people who don't have MS, we can see that one vaccine for a lot of people works well. The problem with these antibodies is that if you measure them at 6 months, they start to peter down. So having a second dose gets you everybody up and stay up for a lot longer. With time, these will wear out. you look at MS patients on B-cell depleting therapies, so rituximab and Ocrevus, we can see that none of them developed those antibodies, and very few developed antibodies, only 20%, and all of them with low levels. When we look at data from other groups, and that was from our group, we can see, for example, that fingolimod or Gilenya has actually less ability to make antibodies than we see even with ocrelizumab. But people who had cladribine, after some time of having cladribine, where the immune system has had a chance then to recover from cladribine or Mavenclad, look like untreated patients and are similar to healthy controls with good levels of antibodies. Some of this is helpful because if we let those in, if we look at when in regard to treatment they had, we can see that the antibodies were higher in patients who were farther out from their last treatment, meaning if you let some of those B cells start to build up, it looks like you had a better chance of making antibodies. I think it's a little bit easier to see from this study from Penn, led by Amit Bar-Or. So here you have the antibody responses, healthy controls, everybody makes antibodies. When you look at then these T1, 2, 3, these are time points, and this is the time points that those represent. And as you look at patients on B-cell therapies, about 50% of patients do make antibodies. So there's this notion of patients on B-cell depleting therapies don't make antibodies. That's not true. We do see that people can make antibodies, and some of these just are really low levels, but even this person made some antibodies. The people who made antibodies tended to be farther away from their infusions, and these numbers are a little bit, they're little, they're really small on a logarithmic scale. And what I mean by that is these are very small numbers. And so you don't have to have necessarily normal B cell levels by the time you start to make antibodies. And so even when we look at people, there's nobody that has 0 B cells in their blood. They just have really, really few B cells. When you look at T cell responses, you can see that the T cell responses look very similar between both groups. As a matter of fact, if you look at the average, it might be a little bit higher in the patients who were treated with B-cell depleting therapies, making the notion that they're trying to compensate a little bit with the T-cell arm to provide some better protection. That's part of the reason why we see that patients on rituximab don't do horribly bad with COVID for the most part. But there's a lot of factors that go into how bad people do sometimes, and unfortunately the biggest risk factor is just random, and some of those things might include like how much virus did you get infected with, did you get infected with a few virus particles, did you get a lot of virus when you got infected, and things like that. So again, T cell responses are good. B cell responses are a little bit variable. In this point, we're going to drive when we start talking about guidance of recommending that at least the boosters be towards the end of these infusion cycles with this. So should I get a booster? The answer is yes. It looks like it helps provide better chances of developing antibodies. And for patients who have moderately or severely compromised immune system, we start to not talk about them as boosters, but as third shots, and then still recommend a booster. What should the timing be? So, we used to talk about 4 weeks. I think we still, if you have not gotten vaccinated, I would still hold to this. I want you to get shots. And if it's a booster, then trying to kind of use the other vaccines to kind of then build up that B cell part. So trying to at least build whatever we can, as opposed to waiting another 4 or 5 months with no protection at all, at least trying to get some protection early. And then as we talk about boosters, then getting towards the end of those treatment cycles. Those extra shots do help. So on Gilenya, we see that if we give a booster, there's no additional benefit for a lot of people to make more antibody. But when you do this on B-cell depleted therapy, about a quarter of patients start to make antibody that were not making antibody before. So if you're starting with 50% and make antibody initially, that would mean 25% of that 50% who did not start to make antibodies. So you're starting to get into the 60-65% range of patients starting to make antibody. And that can be very helpful. And again, a lot of these patients maybe don't technically become positive, but they can provide some protection with antibodies, because you can see that their overall trend is for them to actually start to make a little bit of antibody. And again, this question of maybe these patients need a fourth shot or a fifth shot or an Omicron shot and some of those things. And I think that's the data we're still going to need to collect from now on. So I've updated the vaccination guidance. When we start to talk about initial vaccinations, J&J is still available. I crossed it off here, mostly because our guidance is to not use this vaccine as much as the Moderna or the Pfizer, for a couple of reasons. One, yes, it is more convenient. If this is the only one you're going to do, we're completely fine with you getting the J&J vaccine. But the Moderna and the Pfizer do work better, it looks like. Additionally, they work better if you complete the 2 shots, I should mention. But additionally, the J&J has had a few more issues with clots and things like that. And so because of the risks with this medicine, again, not a ton of clots or bleeds, but we just don't see as much of it with the Moderna and the Pfizer. And if they work a little bit better, then it makes sense to try and stick with these shots. Follow-up doses. It's okay to mix and match. The latest guidance allows us for that. Again, this third dose, if immunosuppress, is a third dose to complete your normal vaccination. If you remember going back to hepatitis B as a kid, or for your kids, you get 3 shots. So it's not uncommon to need 3 shots for certain vaccine series. And then we're going to recommend this booster. The Moderna booster dose is half the regular dose. So for that third shot, we would want the full dose. For the booster, whether you do the half dose or maybe still go for the full dose, knowing the issues of developing antibodies, we would probably just recommend getting the full dose. But for people who are not immunosuppressed, your significant others and things like this, we would recommend just getting the half dose for the Moderna. We want to have you to have some protection. So trying to get that third dose in some time frame, 3 to 4 weeks after the last dose. I put a range. So for Pfizer, 3 weeks, for Moderna, 4 weeks, somewhere in that time range. We want you to complete these somewhat fast. The boosters, this seems complicated, but for Pfizer, 5 months, for Moderna, 6 months. Again, just some time period a little bit afterwards. This allows for the immune system to kind of settle down a little bit and then kind of remember how to make those antibodies. So that's why there's a little bit of a time gap built in there. If you're on infusions every 6 months, based on the data I showed you, we want to kind of shoot for having that one of these doses, whereas the third one, the booster, about 1 month prior to that next infusion. All right, I'm going to go through this real quick, mostly because I went through this at the summit, but some myths about vaccines. mRNA vaccines are new and they have little data to support them. They are new. It's a new type of vaccine. This is the first time we've had vaccines that are mRNA. There's no doubt about that. However, the technology is not new. It has been getting developed since the 80s. And vaccines have been getting tested of this type since 95. So actually didn't update these numbers since November, but billions of doses have been given. And I think we're probably well over 10 billion doses of these vaccines. So when you think about concerns about needing more data, consider that your Ocrevus, Tecfidera, Gilenias were all approved with maybe 10,000 patients having been treated with that, not billions of people having been treated with it. So we have a lot of data on vaccines. We don't, as far as at least for safety. And if you start to look at efficacy, yeah, you can make an argument about Omicron, but I think this data that I showed you from the Sanford Health System shows that it still is providing some benefits for that. They contain a microchip. Unbelievably, this has come up, and the issue is we carry more microchips with us in our telephones and Fitbits and Apple Watches and everything else like this. If you try to figure out what the range is for most of these chips, it's not like a satellite's going to keep track of you. Most of the ones that have GPS availability are going to be way too big to fit into a syringe to get injected into you. If you think about a dog that's been tagged, for anybody that's had that and has had to get checked, you have to get really close to that chip in order to kind of figure out who that dog is and a phone number to kind of reach out to. So not a concern there. The COVID-19 vaccine will alter my DNA. Absolutely not. The way this works is you make RNA from DNA and you make protein from RNA. You cannot make DNA from RNA in humans. So this does not go, these are one-way arrows and you do not go the other way. So this will not genetically change you in any sort of way. The vaccine will make you magnetic. There's no metal in the vaccine, so absolutely not. You can get sick from the vaccine. Possibly, it's not uncommon to end up with some fevers and chills and things like that, sore arms, and things like this. There's a really good webinar I would point out to from Dr. Vollmer, who talks about pseudo relapses from the vaccine. These are, an issue because of the fevers and the chills. They tend to be short-lived, maybe a day or two. They're easily treatable with things like Tylenol and ibuprofen to kind of help bring that fever down. But like most of the times when MS patients get a fever, they tend to have some symptoms kind of come up from their MS. And those pseudo relapses are common. So pseudo relapses, yes. Relapses from the vaccine, no. The COVID-19 vaccine will make you sterile. This has actually been looked at based on a lot of these myths, and the answer is no, and the numbers are there. But we do not see an increased risk of miscarriages or things like this. COVID-19 vaccines are called luciferase. They have patent number. There's no Lucifer in the vaccines. Some of the enzymes called luciferase is a light making enzyme that is used as part of our reporting ability to kind of say we got this gene in or other things like this. This comes from fireflies. You can see this is what helps make the light from fireflies. That's where it originally came from. The vaccine itself doesn't have it, but the technology used to make the vaccines did use that in the earlier stages for it. But again, there's no Lucifer associated with the vaccine. The vaccine can result in blood clots. So this unfortunately is the concern. And this is part of the recommendation against using the J&J shots as opposed to the Moderna and the Pfizer. It's important to remember that COVID itself is associated with clots. So because of COVID, we've seen people develop strokes, both the regular kind of clot type strokes and the bleeding type strokes, heart attacks, and things like this. And so, whether or not there's an increased risk of blood clots in addition to what we're seeing from COVID itself, I think is still a little bit of a hard number. But we have to freely admit that yes, there's a small risk. That is the risk right there. So not a huge risk, a really small risk. The chances of dying from COVID are much higher than that. Ivermectin. You know, COVID is a virus. It is not a parasite. That's what ivermectin got developed for. If you use ivermectin at really high doses in a test tube, yes, it can prevent COVID. So can bleach and many other things. I do not recommend either ivermectin or bleach or hydroxychloroquine or some of these other things, because that is the issue with them. You need to have really high doses that are toxic in the human body in order to use those medicines. If you do use ivermectin, please use appropriate doses and don't take a horse pill, literally, because that's where most people are getting their ivermectin from, is either doses used to treat horses, cows, or pigs. All right, just as a review for risks in MS patients and immunosuppression. So age is a big one, especially if you're over the age of 70. If you're male, you have these comorbidities or other ones. Disability level, I think especially remains the biggest one, and we'll put these in context here in a little bit. Some of our MS treatments might be helpful. Interferons can reduce the risk from COVID. B-cell depletion can increase the risk of MS. These factors are nothing compared to issues around disability, age, and other things like that, and we'll show those numbers here in a little bit. When you look at the number of hospitalizations by age, you can clearly see that older people and patients are bearing the brunt of this pandemic and have a much higher risk, and this was recently updated. When you look at the younger groups, their risk is as high as it has been with any other wave. When you're looking at the older groups that have been much more vaccinated, you can see that their numbers are under what they were for the prior waves. And this is for patients getting hospitalized, so not just cases. So again, this idea that vaccines, even with Omicron, are being helpful in trying to prevent those bad cases of disease. This is data from MS, and this predates Omicron. So this is data from kind of the first few waves. It includes data from the Delta variant. I don't expect that these that the relative numbers for these are going to change much. And so we can see, for example, that as you get older, that there is a higher risk of getting COVID. For every 10 years, how to interpret these numbers is 177% increased risk for every 10 years. 312% increased risk if you're a man versus a woman. When you look at the risk of drugs, rituximab is 281% increased risk. Ocrevus did not see huge numbers, and that might be just because there's not a lot of cases maybe that have reported deaths on ocrelizumab. But when you look at disability, this is a 2,540% increased risk if you're non-ambulatory. So if you cannot walk, this is how much your risk goes up compared to any other risk factor that we normally think about. This is part of the reason why we stop treatments in patients who have higher levels of disability, because of this concern for infections. This is an example from COVID, but you can see this with just about any other type of infection. And we saw very similar numbers with rituximab for any type of infection in our own clinic using data from that clinic. All right, so those are the risk factors. So you have to kind of adjust for yourself to kind of say, how immunosuppressed am I? What's my risk? And those kinds of things to kind of know how much you need to self-isolate and how many vaccine boosters, third shots, and those kinds of things to do. I think so I would say I just spent the majority of this talk talking about the bad news, and that was Omicron sucks and the numbers are going up. I think the important point is talking about, some of the good news that have come up. And again, to highlight how new this information is that there's a lot of treatments coming up. So remdesivir has been used a fair amount now for the last roughly 6 months. And and is still being used actively. The couple of patients that I have in the hospital have received remdesivir. Monoclonal antibodies are not used if you hospitalize or need oxygen. So the idea is for these antibodies is that you need to do this early. There is some concerns because some of the antibodies do not work against Omicron. At least it looks like they don't work against Omicron based on test tube tests, experiments in the lab. So these two that were some of the initial ones don't work very well. So what's different between this versus when we talk about vaccines? When you have a vaccine response and you make antibodies against COVID as a virus, you may make antibodies that come from here versus here, here, and here, and you have a lot of different targets around that virus that can provide some protection. When you get antibodies made in the lab, you basically are finding, binding only at one site. So if that site changes a little bit, then that antibody is not going to work. And that was the reason for trying to combine some of these antibodies, for example. From these early mixes, this is the main antibody that still works against Omicron, as you can imagine, because now everybody's down to using this one main antibody. This one is in really short supply, so it's hard to get. And right now, these antibodies are mostly being sorted out to patients who have 2 or 3 risk factors. So again, really hard to kind of get, and not, I would say almost not really available. A lot of our MS patients in the last week, I would say prior to this last week, we're able to get them. This past week, it's gotten a lot tougher and they're getting a lot more rationed out. And the pharmacists at the hospital are monitoring and really trying to kind of identify patients at the highest levels of risks. So having MS is not a risk. Being on a B-cell depleting therapy is a small risk. Being 70 in a wheelchair on Ocrevus starts to add a lot of risks, but those risks still don't add up to, for example, cancer patients who are really, really immunosuppressed. And that's kind of how they're trying to kind of measure it. Depending on how they get antibodies, they distribute that out based on criteria that they're constantly adjusting. Evolshed is a new combination of antibodies. I am not even going to try to pronounce these, who do appear to have efficacy against Omicron, and they're being used as a preventative. So the idea is you would get this combination and then have some protection kind of longer term. We would love to be able to use this for some of our patients. Again, the challenge with this is availability, since it just got approved, I believe, last week or the week before that. I forgot to put the date on here. Right now, through the University of Colorado, I can tell you that Evolshed is being only used for cancer patients who have who are getting chemo, and chemo in the sense of what we think about as chemo with kind of like big duty type chemo, not hormone chemo or other types of treatments that don't affect the immune system quite as much. So right now, the little bit of drug that's coming in is going to that purpose. We had a few questions, great questions actually, about IVIG, convalescent plasma. So IV is intravenous IG immunoglobulin of the G type. IgG is another name for that. This is what convalescent plasma is. Basically, convalescent just means IVIG made from people who have gotten sick and have gotten better. So we take their antibodies and give it to people. IVIG is a little bit more broad. So this could be helpful. I can tell you convalescent plasma is being used. The problem, remember, again, is against Omicron specifically, that not a lot of people have gotten a chance to recover from Omicron yet in order to make this convalescent plasma. IVIG takes a little bit longer to kind of process, just they're really careful in how they purify it specifically. And so, mostly the IVIG that's out there is going to be from the days of maybe having some Delta stuff. And so because some of those patients who recover from Delta would selectively get put into this convalescent plasma. IVIG may have some protection against COVID, but it may not have a ton of antibodies directed against COVID. The good news is that because of vaccination, there is probably some antibody from the vaccines against this. And because here you make antibodies to multiple different areas of that spike protein, is that this could kind of give you a lot of variety against Omicron. And so again, not maybe a very enriched way to get these very specific antibodies, but it can probably provide some protection. More exciting, I think, than some of these treatments are now we're starting to get small molecules, small proteins, like you think about any pill that you would take, kind of small molecule type stuff. Paxlovid in combination with ritonavir is an antiviral that works really well, it looks like, against COVID. The data that was announced was from November, and so how helpful it is against Omicron, we don't know. But there were no deaths in those patients treated with this drug. There were 10 in the placebo arm. This just got authorized, emergency use authorization on December 22nd. So still very new. I can tell you that the university has gotten a few doses, but it's been impossible to kind of get even for my patients at this point. And I can tell you they're not using it even for patients in the hospital, again, saving it for the highest risk patients. Molnupiravir or something like that does cut hospitalizations and death by maybe 50%. So maybe not as good as the Paxlovid. Two other companies, this is a generic molecule that's out there, so a couple of other smaller companies did similar studies and they didn't see that it was effective. I think because we're a little bit desperate, this data had come out even before Paxlovid. It finally did get this emergency use authorization, but it came afterwards. And I think it's the idea of, hey, we're not probably going to get a lot of this anytime soon. So let's try and get anything that we can. And that's the reason it got authorized for use. So again, if given the option, I would much more go for this drug or maybe even some of these monoclonal antibodies than maybe this molnupiravir. But again, remember, we can use some of these drugs, early on if hospitalized. They didn't have some of the restrictions the way that the monoclonals have. So this is kind of where the infectious disease docs are really busy trying to kind of say, early on, maybe want to use monoclonals, later on, maybe want to use more of the small molecules and things like this. And so the point of the story is there are smart people that know much more about this stuff that we're relying on to kind of help sort out how to actually treat COVID. So what should we do? So in the past, I would say that vaccines do protect everybody, but appear to protect from bad COVID. And I would say that it does appear, we can get rid of the appear. They do protect from bad COVID. It's 100% definitely not, but there's definitely a big reduction in bad COVID. Treatments are slowly becoming available to treat COVID. Just got done discussing this. Very exciting. Much more data will need to be obtained. How much will it help against Omicron and all these things, still to be decided. With patients who have B-cell issues, we're depleting them, sequestering them, basically meaning we're keeping those B cells in lymph nodes using drugs that affect S1P. So think about Gilenya, ponesimod, ozanimod, or siponimod. These drugs can affect these B cells. The vaccines aren't great, but it look like boosters kind of continue to help. They help build up those T cells. The B cells maybe do need a little bit more help. The T cells are helpful again, and we do see that the risk of death for patients on these drugs isn't increased compared to the general population, although the risk of ending up intubated or in the ICU are increased about threefold. So you're at a little bit higher risk. So mildly immunosuppressed is the way I tend to think about most of these drugs. rituximab got put into the category of moderate immunosuppression. So get vaccinated, including boosters, third doses. This is by far the best, easiest way to provide prevention, and they're very safe ways to do that. And then I think we have to weigh that from a mental health perspective. I know right now may not necessarily be the best time to kind of tell you to get out of the house. A, it's freezing outside, but B, everybody that you know probably seems to be coming down with COVID. So limiting interactions, I think, for the next few weeks, I think is going to be key. We'll get past this wave like we have all the other waves, but figure out how to interact with other people. If it's outdoors, if it's with masks on, if it's remotely through Zoom meetings or other things like this, figure out a way to interact with people. I think that's important. Don't forget to exercise, to eat right, and overall just try to maintain that overall be well perspective. And so with that, Kelsey, let's turn it over to the million questions that are probably accumulating on the chat and previously.
We do have an awful lot of questions. I'm going to just reiterate that we are unable to give specific medical advice out. If you have questions regarding your specific treatment plan or your specific timing, we encourage you to reach out to your neurologist. Also, if you're looking for some of the more general background information on COVID and MS, we have lots of other webinars on our COVID-19 education page at mscenter.org. So now we're going to move into the Q&A portion. I have been trying to group similar questions together, but there are definitely more than we will be able to get through today. Some of the questions submitted at registration have already been answered. We have a lot of questions on timing still. I'm wondering if we could revisit your timing slide. Some of the questions coming in have been, if you got 2 full doses and then a booster 6 months later, should you be, but you got Moderna, so you got the half dose for a booster, should you be worried about getting a 3rd full dose, or should you try to get something beyond your booster?
Yeah, so there's no risks with getting extra doses. They're just not pleasant. So I get not necessarily wanting to volunteer for more shots, for example. Figure out if I can do this the right way. Is that coming through?
I'm not seeing it.
Okay. So I think the idea is, if you don't think that you mounted good antibodies, that it might be good to think about getting another booster or another shot if you can, if it's possible, if you get it. I've had patients get up to 6 shots already. Weird circumstances and situations. They were in Mexico living, and they got a Chinese vaccine that's available there. And then they came into the United States and it wasn't recognized, so they got some of that. One of the patients ended up going to Canada, and in Canada they had not the AstraZeneca vaccine. So they got the AstraZeneca and then needed something else to get here. And they said, at this point I've gotten a Chinese one, I got the AstraZeneca, I'd gotten 1 shot of Pfizer, and now I'm going to get a Moderna one in the United States. And so they went through and got it. I'm not sure if I'm sharing the right screen.
I've got just regular PowerPoint, not the presentation mode.
Slowly getting there.
There we go.
Perfect. And is it the full screen one?
Yes.
Yeah.
And can you just touch one more time on the difference between the booster versus a third dose?
Yeah, so to emphasize it, right? So Moderna and Pfizer have the 2 shots. Pfizer's 3 weeks apart, Moderna would be 4 weeks apart. The idea is then you would get a third shot if you were on drugs that we would consider to be immunosuppressive. Um, there's no standard definition by this. So the people that I would push strongly towards doing this would be patients such as on the S1P and drugs, such as Gilenya and similar drugs, or the B cell depleting type therapies. So those people, I would want a third shot. And then for people who have not had COVID, especially, then I'm really pushing towards boosters. If they had, sort of a bad COVID case, then I call that a booster and I'm okay with that. If they're okay getting a shot, I still tell them to get, another shot and get a 5th exposure, just because I think little by little you start to make those antibodies. And not just that, but you make longer term antibodies. We have to remember that the coronavirus is the common cold. And obviously this has not been just the common cold. But the common cold only has 4 viruses, and they kind of go around and they spread, and we tend to get them about every few years. And so sometimes we get them and we get a very mild case, and sometimes you get a common cold that's not so common, and it can kind of kick your butt a little bit more. Why? Probably because you've not had another common cold recently, so your antibodies have kind of dropped off and not made as many, and things like that. So trying to kind of figure out how to maintain those antibody levels becomes really important. Sometimes with these vaccines, you make antibodies and you make them for a long time. Unfortunately, with these types of viruses, they seem to be short-lived.
And does your advice on getting additional shots change for someone on Tecfidera?
Yeah, Tecfidera, I would kind of put them in sort of like a little bit less concern, but I would still, probably follow the same guidelines for Tecfidera. For patients on interferons, Copaxone, I don't worry about doing the 3rd dose. I think those patients are probably just fine with the 2 main shots and then a booster 6 months later. Tecfidera is a little bit tricky because it just depends on sort of like how your lymphocytes are and everything else that kind of goes with it. As we get older, we don't respond to vaccines quite as well. So if you're older, I would push you more towards getting extra shots. If you're younger, I don't worry quite as much about, getting those extra shots. There's a little bit of wobble, and I understand that that's frustrating, but it's part of this issue of, not all of our immune systems are affected the same way.
And is there any recommendation or ability for folks to know if they have been mounting that antibody response?
Yeah, great question. So there's now ability to measure those antibodies pretty easily through the clinic. They're using a lot of those resources just to test for COVID. So over the next month, we may not want to be doing a lot of this, mostly because a lot of times these other preventative antibodies, for example, are not yet available either. Once we start to get like some of those preventative antibodies available, then we will probably start to test those antibody levels. So the criteria for getting those drugs is that you're moderately or severely immunosuppressed and don't have antibodies against COVID. That's going to kind of have to, there's been a lot of discussion within our group, for example, of like, would these treatments be available for people who have not gotten vaccinated? Things like this, meaning like if you've not even tried to make antibodies, would you benefit, or should we take this really kind of precious resource and give them available to to some of those patients. And I think that's kind of where medical ethics kind of has to come in a little bit and help us decide. At this point, again, they're not available. We don't have enough of it around. But as we get enough of it around, we will have to kind of start figuring out who's going to get them and those kinds of things. My suspicion is that once they become available, we will start to look at patients who have higher levels of disability, who are older, who have those risk factors that put them at higher risk on things like rituximab and Ocrevus and Gilenya type drugs.
If somebody got their COVID shots before they started their Ocrevus treatment, is there a diminished effect of the vaccine at that point?
Yeah, great question. So you definitely appear, so if you would mount a normal immune response, so you would likely have good antibody responses. And then the question becomes, and this is the point that we don't have data for, is do those antibody responses drop down a little bit faster, or do they stay up? My suspicion is they probably would stay up the same as with anybody else, mostly because at that point, the cells that make those antibodies are the plasma cells, which are not affected by these drugs. And so you would continue to make antibodies once you get to that stage. So that's kind of a reassuring sign of that as well.
What recommendations do you have for timing of getting a flu shot, both in conjunction with their COVID booster and/or infusion treatments?
Yeah, no, another great question. So technically, I can say that it's okay to get all your shots all at the same time. And that just brings horror thoughts of when my daughter got, I think, 5 shots in one day at the pediatrician's office. But for the most part, if you have the time to go get shots on different times, I would personally try and separate them out. The flu shot this year appears to be a little extra stronger and kind of beat people up a little bit more. And so, being able to kind of separate that out from feeling cruddy from the COVID shot, same thing as like the shingle shot or any other shot, trying to separate those out, I think makes a little bit of sense as well. They're saying that you can do them all at the same time, mostly from efficiency perspective. Hey, they're in the clinic, let's just do it. But if you can separate them, I'd separate them.
What is your understanding of how easy it is for patients to get another shot? Have you heard of any patients being denied additional boosters?
I have yet to hear of anybody getting denied a booster. Sometimes I think for 1 or 2 people, mostly who were getting their 4th shot and trying to get them in kind of pretty fast, we had to kind of write a little note or something like this. But I've known a lot of people with getting their 4th shots who when they came and told me about it, there was no batting of the eyes from the pharmacy. It was like, which arm do you want it? And sign here and let's move on with it.
And you discussed earlier some of the side effects of a possible pseudo-relapse from the vaccine. And in the myth section, you described some other possible side effects. Are there any other side effects people should be aware of with the vaccines?
Yeah, I mean, those are the big ones we have seen. We talked a little bit about clots. Again, small risk factors that way. There's been a lot of discussion about whether vaccines could actually give you relapses. And I think we have, again, a good webinar to kind of address some of those issues. We have seen some relapses after vaccine, probably 2 or 3. Given the number of patients who develop MS that we see, I'm not surprised. I would be surprised if that we haven't seen more of that, honestly, just because it's really common. There are kind of similar other conditions that we sometimes would see, like Guillain-Barré's and ADEM type of conditions after vaccines that we see periodically with the flu shots or other vaccines that occur in the range of like 1 in a million. And so, we can see some of those kinds of reactions, and I have personally seen one. But if you consider the number of lives probably saved by the number of vaccines given and things like this, that is a small drop in the bucket in kind of the bigger picture side of things.
If somebody has delayed infusions while data has been collected for COVID and the vaccines, should they be talking to their doctor about getting back into their normal treatment routine?
Yeah, I think one of the things that we're seeing is people have been kind of dropping off clinic some, and it's a good time-ish to kind of reestablish care. We are kind of starting to think about maybe having to switch a little bit more to telehealth over the next few weeks. It's mostly less concerned about safety in the hospital, but what I can tell you is one of our MS nurses, for example, right now has COVID and is working from home. She's been vaccinated. She's got mild COVID. She's got a runny nose. I talked to her this morning. This kind of stuff. And because of some of these things, just to try and allow for some of that, for some of the work to kind of continue getting done, being able to switch to telehealth for that has been, something we're considering.
If somebody has recently had COVID or if they have symptoms, what are recommendations for getting their infusion?
We're getting this question a lot, as you can imagine. In general concepts, what I would emphasize is that I want you feeling better before you get an infusion or treatment. I think the one concern would be with Tisabri. I wouldn't want you delaying your Gilenya pills much. We can push them off sometimes a week or two. Gilenya after 2 weeks, you got to do the first dose observation. There's rebound with Tisabri. After 8 weeks from your last infusion, we can see some rebound of disease activity from MS. So in those kind of situations, we really want to have a good discussion about kind of where are you at and that kind of stuff. And so I think that reaching out to the clinic becomes important. For other cases like the infusions with B-cell depleting therapies, those are every 6 months. And we know early in the pandemic, we were pushing them off 2 months easily. It's okay to push them off. And so, if as long as you're past the fevers and are starting to feel better, then let's start considering, getting you treated.
Should patients or their doctors be notifying a neurologist if they have COVID?
I think it's a good My Health Connection message. Hey, just FYI, I have COVID, doing okay. I am trying to reach out as I get time to kind of patients that I know have COVID, just to kind of double check, making sure that, things that we might be able to provide with, answer questions we're trying to do. But people are dropping like flies and it's hard to get to everybody. And our nurses are inundated right now taking messages. And it's partly because of that, if you can just let us know, give us a heads up, that's great. We appreciate it. If you do have questions, feel free to reach out. But part of the reason we're doing these webinars is to kind of try and get as much information to everybody to kind of help reduce some of the numbers into clinic, just because we're frankly kind of getting a little inundated right now. One of the things that we get a lot asked, Kelsey, that reminded me from the prior question is about getting the monoclonal antibodies and if that affects the B-cell depleting therapies. And the answer is no. So there's no concern getting any of these treatments from our MS treatment perspective. So it's okay to get these treatments, from that perspective.
Do you recommend that UC Health patients go to UC Health if they get COVID, or would that increase the likelihood of immediate treatment, or do you think just their local urgent center?
It's a tricky one because I don't know the situation at a lot of the other hospitals, and it's quite variable at some of the other hospitals, right? So I would say at UC Health, there's a little bit of a known standard of care that we can kind of provide. I would say the state is rationing these drugs out fairly well. So there's not a lot of priority to one hospital or the other, as far as I'm aware of. I think sometimes the severity of patients at the U is a little bit higher. So sometimes getting some of these treatments may be easier somewhere else. But that's pure speculation. And again, highly variable from one hospital to the other. So if you live close to UC Health, I would come to UC Health. I wouldn't drive an extra long distance to come to UC Health. Patients can be transferred from hospital to hospital, and if we feel like patients aren't getting the care that they need or can get at the U, we're working to try and get those patients moved over. But I showed you the numbers, and that's right now at our system, it's about 15% of our beds are COVID patients, for example, and we didn't have a lot of flexibility to begin with. So that's been the challenge a little bit. Don't have a lot of free beds to kind of move people over.
Let's talk a little bit more about recommendations for being out in the world right now. Can you talk a little bit about the best masks for protection? We're hearing some folks say not to use cloth masks anymore. What are your recommendations?
Yeah, I think it's I think rule number one is you got to wear a mask that you are going to wear appropriately. A mask worn around your chin is not going to be helpful. A mask that has loose sides along the side isn't going to be helpful. So you need to have a mask that fits well. That is much more important than the specific material or type of mask. N95 masks are, I don't want to say kind of the gold standard. They're the ones we hear a lot about, and you'll hear designations by letters, KV, KN, N95s, things like that. Those are great masks. The challenge with them is that as you start to kind of restrict the airflow through the mask, I can tell you, for example, with my beard, that an N95 doesn't do jack squat above a surgical mask or a cloth mask, because with the beard, it just kind of lets the air kind of go through. And technically, you would have to be clean shaven in order to properly wear an N95 mask. You definitely don't want to wear the bandana masks because again, they don't fit well. It's a thin piece of cloth, so having multiple layers of cloth will be better than a single layer kind of a thing. Double masking, those kinds of things. I see a lot of people that then when they wear their second mask, for example, there's a lot of gaps on the side and things like that. That doesn't add any protection over just the one mask. And so for most situations, I wouldn't worry about double masking. The biggest challenge that we have is not so much the type of mask, but it's kind of how do you position the mask and all that kind of stuff. And what I mean by that is if you're wearing a mask and you're constantly fidgeting it, you may go reach out that door handle, and then you go grab that mask and you start to kind of adjust it up and down so that it keeps over. You just took all the COVID from that door handle and spread it all over your face. So that's where having a very kind of comfortable fitting mask that you're not picking at becomes really important.
And what other recommendations would you have for folks being out and about in the world, kind of thinking about indoor spaces versus outdoor spaces? How often should you be testing if you have access to rapid tests?
Yeah. The outdoor spaces are always preferred for a number of reasons. One is the airflow kind of helps push that virus out. So if it's hanging out in space, they're just going to push it out. On the indoor side of things, you have to kind of think about how tight of quarters are you in, and things like that. If you're in a big open space, indoors, it's usually not a big deal. If you're in that big indoor space with 10,000 of your closest friends, then it becomes a concern for that. So I think it's really important to kind of assess, and one of the examples I use sometimes is like looking at a restaurant. You look in through the door and you'll see everybody wearing a mask, and the tables are nice and separated from each other. Yes, it's indoors, but the food's coming out hot. It's been disinfected in a sense through the oven and things like that. The guy who's bringing it to you or gal is wearing a mask and hopefully washing their hands well and things like this. And then you have space between you. Those are really comfortable, safe settings. I think that really good to kind of go out and enjoy that. If you peek into a restaurant, a Walmart, a grocery store, and nobody's wearing their mask, or very few people are going kind of crazy, they're touching everything, those are the places where I'm a little bit more hesitant to kind of go into. And again, especially now, 3-4 weeks ago where numbers were down, I think it's a little bit safer to kind of do those things. But knowing kind of what the rates are, is there a lot of it going around and things like that becomes important. So it's taking all those things kind of together and trying to make sense out of it. Kelsey, one of the ones that's come up a couple of times I saw was the long COVID thing. And so we can address that a little bit. So long COVID is something I don't know that, or at least I know I don't understand it very well. It is sort of symptoms that last a long time after COVID. And some of it makes a lot of sense. In patients who have lung COVID, for example, where they get a pneumonia from the COVID, the virus actually affects the lung tissue. The lung, for example, is one of those tissues that it can kind of repair itself, but it takes a really long time because it doesn't have a ton of blood flow because half the other side is airflow. And so it takes a long time to kind of get rid of junk, to get the nutrients to kind of fix the lung. And kind of like patients who have bronchitis and other things like this, or even just other types of pneumonias, it's not uncommon to end up with COVID in those situations that can last, for 6 months or things like that. So some of that will gradually get better, but it can take a long time. Because of patient, and one of the examples was about, on Ocrevus, is there a higher chance of this? The answer, I think, is yes. I don't think it's a huge chance much more, but as we said, patients on Ocrevus are 2 to 3 times more likely to end up in a hospital being intubated and things. So I would say that their chances of developing lung pneumonia type stuff is 2 to 3 times higher, and that's probably the risk of developing long COVID. That's a hypothetical answer, but about as good as we're going to kind of get.
And I think we are running out of time. As far as we just covered long COVID, what is the mechanism of action for Vumerity, and where would you put it in the recommendations?
Yeah, you can basically replace all the comments about Tecfidera and put Vumerity in there. The active drug is the same. It's just how you get to that active drug is a little bit different. And probably because of how it gets broken down, has a little bit less of the GI tolerability issues. The vast majority of patients on Tecfidera and Vumerity, monomethyl fumarate, which is called banfirtine, can have really normal levels of lymphocytes, but some patients will go on to have lymphocyte counts that really drop off. I shouldn't say huge drops, because we usually don't keep patients who have big drops, but if you have mildly decreased lymphocytes or more moderately decreased lymphocytes, then you're a little bit of higher risk. So the cutoff number that we see when we're looking at it is the absolute lymphocyte count that we're monitoring for that. That's why we find the vampires every time you come into clinic. And so sometimes we abbreviate it the ALC. That number, depending on the units, we'll sometimes say 0.5 or 500 is the threshold. So below that, we almost always switch you to a different drug. We might test you a couple of times. If you're kind of in that 500 to 800 range, or 0.5 to 0.8 range, those would be the patients I'm maybe a little bit more concerned about. But for the most part, I would put it in kind of a better category than the B-cell depleted patients or the Gilenya patients.
What fever point would you recommend someone going to the ER?
Sorry, we ended up discussing for about half an hour at one of our meetings what a fever is. I think a fever is one of those things that it just depends on how you're doing, much more so than an absolute number. In other words, if you have a fever and you're doing okay otherwise, breathing okay, it doesn't bother me that much. If you're starting to get into high fevers where you're starting to get chills, where you're starting to kind of get, especially rigors, your body's just starting to kind of do this, and you can't, you take maybe a round of Tylenol, ibuprofen, and it's not coming down, that's time to go to the ER. It's an indication that you should try and do something. If you've not tried something, I think that's okay. I get much more worried about looking at oxygen levels and making sure that you're breathing okay. And if you're starting to feel short of breath, you're done, go to the ER and get checked out. So to me, that's a much more important marker. And one of the things that we start to kind of think about is, if you can, having a pulse ox, pulse oximetry to kind of actually measure those oxygen levels, to kind of help with that.
And as we wrap up, let me know if my summary sentence is accurate, or fill in the blanks. The prophylactic, proactive kind of treatments are in very short supply right now, so we are unable to give them to all MS patients who might want them.
They're not available to MS patients at all.
Okay.
So at this point, it is, they're slowly kind of making it out. They're being specifically given to cancer patients who are much more immunosuppressed than our patients are. And as they become available, we will be updating our guidance for some of these things. But at this point, they're not available. The Paxlovid, the antivirals, are not available. How soon they become available, I heard we just got a shipment in, and they're trying to kind of figure out, sort of who the highest priority patients are for these. So that's where we're at as far as some of those options. So again, a lot of promise, but we're still stuck a little bit.
So I would encourage everyone to make sure they're on our email list, because if we update recommendations, we will do that through either our EMS newsletter or another update webinar. So please make sure you're on those lists. And then one final kind of wrap up statement: if somebody, particularly somebody on an anti-CD20 gets COVID, what would be your suggestion? We had a lot of questions about the monoclonal antibodies being their first step, or what immediate steps should someone take?
Hey, Kelsey, I'll throw in a couple of quick ones, just because just to point out a couple of things. I'm just looking at a couple of quick questions, and I realized I didn't touch on it. Rapid test, as far as ability to test for Omicron. Rapid tests are a little bit hard. I can tell you some rapid tests are picking up Omicron, because some of our patients have used rapid test to pick it up. But it doesn't, there's been some reports that some of them may not pick it up as well, meaning you may need to have a worse infection, more of the virus, in order for the test to pick it up. But it would tell the difference between that versus a cold. I mean, it won't tell you it's the common cold or other things, or the flu, or it won't tell you the name of the other one, but it'll tell you like, yes, it's COVID, and that kind of stuff. And again, just based on what's floating around now, it's Omicron, and not one of the other ones. There was one other one I was going to make a point on. The other one wasn't as important. So I forget what I was going to say, and we'll just leave it at that.
We did have an awful lot of questions today. I want to thank everyone for your participation. And thank you, Dr. Alvarez, for your time. I don't know if you have any final words you want to wrap up with.
No, I appreciate everybody for joining in. I think, thank you for all the questions, because it definitely, I try to tailor the conversation a little bit around sort of the questions and areas that I can, kind of see that maybe aren't quite, we're not doing a great job of communicating around. Oh, I remember what it was. And the guidance keeps changing a little bit about sort of the period around quarantines and that kind of stuff. To be honest, I expect it's going to change again based on people not being so happy with the quarantining period. So right now, what happened is, because COVID is probably starting a little bit sooner, probably ending a little bit sooner, that if you're asymptomatic at 5 days after your exposure, you can stop quarantining. In the past, it was 7 days. Before that, it was 10 days. So it's just trying to kind of get people maybe back in the community. Again, that is if you're feeling well. So if you're not feeling well, please extend that out. If you need a doctor's notes to kind of say, hey, please, do this, feel free to send us a My Health Connection message. And as much information as you can put in there, if you can write the little bit of notes so that the nurses just have to like copy paste it and know exactly who to send it to, that would be awesome. We're happy to do all those work, excuse letters and things like that. I would think you may not need it, but it's just, it's so important to kind of try and break this cycle, that if you're not feeling well, please stay home.
Thank you. A couple of questions that we didn't get to were kind of more general. How does MS interact with COVID, or vice versa? And we have covered those in previous webinars. So again, I would encourage folks to check out some of our previous webinars on mscenter.org. That's where this webinar will also be archived.
Perfect. And I think just on that comment, the last comment I would make about that is thinking that MS is not an immunosuppressed state by itself, that in MS, the issue is actually too much of an immune system. That's why we immunosuppress things, to try and have things kind of quiet down a bit. And so from that perspective, that's why we don't think about MS as an immunosuppressed state until the disability starts to kind of get up there. And then that's where we see the risk of infections kind of popping up. With that, I appreciate it. Thanks everybody for listening in. Hopefully that was helpful. And we will plan probably for another one at some point once we get more information on Omicron. It may be, several weeks away to a month, just because I don't expect that this data will be coming up for a little while. But if it does, we'll do it sooner. And Pete Broderick and Kelsey put these things together in no time, so we can move pretty fast if we start getting enough stuff to make it interesting to kind of have one. And with that, I appreciate your guys' help and participation. Thanks.
Thanks, everyone.